Hello and welcome to Health Matters on Channels Television. It's great to have you join us. I am Mary Alale Yusuf. At the beginning of the year, residents of Ekpene Eki in Cross River State were scared they had a case of polio in a little boy. The condition was later identified as Talipes equinovarus, which is the scientific name for clubfoot. According to the World Health Organization, approximately 100,000 children are born with clubfoot worldwide every year, 80,000 of them in developing countries. It is an inborn deformity where one or both feet are turned inwards, causing a child to walk at best on his ankles. In the studio with me is an honorary consultant trauma and orthopedic surgeon at the Lagos University Teaching Hospital, Ikeja. He's also a senior lecturer at the College of Medicine in that university and is a certified Ponseti Clubfoot practitioner. Dr. Ladipo Adewale, you are welcome to the show.
Thank you very much.
Now, just for starters, let's be clear. Is clubfoot infectious?
It is not.
It is not?
No.
So no need to fear?
No, you can't.
As they did in Cross River State?
No.
Okay. So what causes feet to turn inwards?
Well, the truth is, we don't really know what exactly causes clubfoot. What we know is that if you have anybody with a clubfoot in your family, you are more likely to have it than someone who doesn't have.
Oh, so it's kind of hereditary.
Yes, there's some genetic and some environmental factors. We also know that if you have one child who has clubfoot, the chances that another one would have clubfoot are higher than normal. So many scientific theories about the causation. But we know for a fact that some of these club feet are what we call positional, just from the child being in the womb and being curled up, and those ones generally just sort themselves out. So sometimes you have only a club foot. Sometimes that club foot is in association with other abnormalities from birth. So the ones that
makes it more complicated, yes, doesn't it?
Those are what we call the non-idiopathic ones. Sometimes there's a spinal cord problem that affects the nerves. Sometimes there are muscular problems that make the muscles so stiff that they tend to turn inwards. And when you have these things, then the child can have a clubfoot.
Are there any risk factors you can point to that, make the occurrence of clubfoot more prevalent?
As I said before, we don't really know what causes it. I think the attention should be directed right now at catching it early and preventing neglected clubfoot, which is what we should be looking at now. Okay,
catching it early. But before we go to catching it early, how easily detectable is it? Is it something you can see as soon as the child is born, or something you can see during the ultrasound scan?
Yes, definitely a good sonographer, that means a person who does ultrasound, should be able to pick up clubfoot whilst the baby is still in the womb. But it's so obvious. In a study we did, most of our patients were diagnosed by either their mothers or relatives or somebody. They weren't really...
When they were
born, they would just say, look, this foot is abnormal. So what we've done in a lot of public health institutions is that we've showed people that, look, this is what a normal foot looks like. If it is abnormal, send to us so that we can deal with this.
I know you said that there isn't any clear-cut cause, but there are just circumstances around, what causes it. But this clubfoot, are there any ways that doctors try to prevent it, like, some kind of medicines that a woman takes when she's pregnant or anything like that?
Well, again, I would say that since we don't really know what causes this, preventing it would be a big deal.
Because I'm aware that sometimes it occurs with the curvature of the spine.
Yes.
And and we've been told that can be prevented with folic acid tablets earlier on in the pregnancy. Yeah. So I was just wondering if that can also stretch to the clubfoot.
No, not from that point of view. You see, what we're talking about now is what we call the idiopathic clubfoot, which just occurs and
on
we don't
its own.
really know what
Okay.
causes it.
Okay.
It's commoner in males, about 2 to 1, and it affects both feet. In about half of the cases, 50% of the cases, it affects both feet. So we really don't know. I keep saying, I wish we knew. We scientists should really find out what causes it.
But it's something that you can actually handle once you see it.
Oh yes, that is the beauty of the clubfoot. I always tell my students that if I were to choose a congenital abnormality to have, I would choose clubfoot, because I'm sure that it will be corrected.
It will be corrected
very easily.
At least if you fall into the right hands.
Yes.
Because some people do grow up with this condition and nothing is done.
Yes, yes. I always remember the case of a 7-year-old boy who walked into my clinic. He was called Boluwatife, which in Yoruba means that's how God wants him. And by the time we corrected the feet and he was foot flat, I told them that they shouldn't bother to change the name, because this is still how
God wanted it to be. Okay, now we've been told that the traditional way we back a child corrects a lot of things in the legs. Is clubfoot one of them?
No. Developmental dysplasia of the hip, that means when the hips are dislocated from birth, can be corrected by backing children, but not unfortunately not.
Okay, so what's the solution? Must we resort to surgery?
Well, fortunately, things have changed. When I was in training many years ago at Ibobi, we used to use the traditional method. We used to cast and so on. We used to use up to 20, 24 casts, and we used to do surgery a lot in a large number of those children. But there was one gentleman in Iowa in the USA who was originally from Spain, Ignacio Ponseti, who championed a treatment.
The Ponseti method. Does it look like what we just had on the screen now? Perhaps they'll put it up again. Okay. A Ponseti method. Go on, tell us.
Yes, and this method is revolutionary because
there it is now on the screen. You could just take a look.
Yes, well, you see, that's just a method of casting. Yes.
Okay.
Yes, but really, the Ponseti method prescribes a method of manipulation. What happens is when the feet are curved, the practitioner tries to straighten out the feet using a specific method. So the babies come every week, and they do the manipulation, and then they put a cast. So we stretch it, and then we hold it in a cast every week. Usually, after about 5 casts, that's in 5 weeks, the feet will correct.
5 weeks?
Yes. But sometimes...
That's approximately 35 days.
5 weeks, yes. So, yes. Sometimes the foot is still pointing downwards.
Okay.
So we do a little office procedure. I can't call it a surgery really, where we just release the tendon at the back. That's the Achilles tendon.
You do a tenotomy.
Yes, and then we put it in a cast. But the problem is, once it corrects, to keep it corrected, they must use special braces. They're called foot abduction braces. These braces have to be worn until they are aged 3 or 4 years. Because we found out that when they recur, it's because they did not use the braces after the feet were corrected.
So the condition does come back sometimes?
Yes. So the braces help to reduce drastically the number of feet that recur. So it's not just a once and for all treatment. Yes, it corrects in 5 weeks, but the treatment really goes on until they are 4 years.
Can you describe what these braces look like?
Yes, well, they're like shoes, but they are connected by a bar, and then the feet are rotated outwards. So the child, they put it on. That's why we like to catch these babies early.
Okay.
When they're little babies, after the 5 weeks, for the first 3 months, they wear the braces all the time. That's 2 shoes connected by a bar.
2 shoes connected by a bar yes. can be worn by a baby.
Yes.
But how about if the person, is
an adult,
2 years old, 3?
Yes. What happens is, initially it's all the time for 3 months, and then thereafter they wear it only at bedtime, when they're sleeping or when they are napping. So in the older child, obviously that is difficult, but we get them to wear special shoes that keep the feet corrected. But at night, they still wear these braces when they go to bed.
And shoes in themselves, I mean ordinary shoes, they cannot straighten the feet. Assuming the mom says, this child's foot is turned in, okay, let me buy shoes. Can't that help?
No, it won't help, because the feet have to be manipulated. There are some tight structures in the foot that need to be stretched. So it's not just the shoes, it's stretching it and then holding it in a cast until it corrects, because the bones, the arrangement of the bones in the foot, in the hind foot, is a bit distorted. So it's the manipulation that brings these bones back into alignment. And then the cast is held, is put on just to hold the alignment.
The foot in place.
Yes.
Okay. You say that a child has to be brought very early to the hospital. Is this as soon as the child is born?
Yes, as soon as the child is born.
But this sounds like a really painful thing when you talk about manipulations and realignment of bones. Do you use anesthetics to do this?
No, we don't, because it's not we don't use any energy per se. We don't force anything. It's a gentle manipulation, and we use a specific technique that is not painful.
Okay.
The only part of it that may be painful is when we want to do the tenotomy. And we have options. A lot of the time, we just put a little local anesthetic around the tendon, so the baby doesn't
release
feel
the tendon.
Yes, when we're doing it, the baby doesn't feel the pain of cutting the tendon.
What happens if a person is not brought to the hospital and grows up with the clubfoot, maybe to the age of 14? Can you still manipulate?
Yes, we can. But you see, when a child comes in at the age of 14, his problems are not only physical.
Okay.
They are now emotional. They are psychological.
Okay, so these are some of the things that the condition causes in a person.
Yes, because I mean, if you're a child and you have a deformity at school, other children will make fun of you and things like that. So generally, there are other issues apart from the physical deformity. And that's why in the Nigerian Sustainable Clubfoot Program, we are determined to eradicate all cases of neglected clubfoot by treating them early. However, this Ponseti method I'm talking about can still be used at that age.
At 14?
Yes.
How about even older? Well, maybe 25, 40?
Yes, there are some studies from Brazil and a few South American countries where people have reported success in teenagers. But I don't think at 40 it would work.
It's almost laughable, thinking of a man at 40 with shoes that are connected in the center by a bar.
Yes, Yes. So
but at that age, what would they do? Would they now have to sort of force it by surgery?
Yes, they would have to.
But would such a person still have hope of walking, assuming he's been neglected all this time to this, a full adult?
Yes, he would still walk. However, we know that surgery is more associated with pain and stiff foot, which is why we say we don't want to perform surgery in the babies. But in an adult, we wouldn't have any choice. We just have to operate.
Are all cases successful?
That's a tough question. I mean, we know that by nature you can't get 100%. But I can tell you that using the Ponseti method, varying studies have showed that a minimum of 95% success rate with that treatment modality, which is good.
Okay, so when we come back from a break, we're going to take a short break now. We'll come back from the break. I want to look at this 5% that might not get better with this method. Please stay with us. We're coming back after this short break.